interesting cases by our young residents, دكتورة ماريا ويليام ودكتورة بنت الله نشأت.
Good morning. My name is Maria William, radiology resident at Ain Shams University. Now I will present a case of female reporting group. Under supervision of Dr. Asma Magdi and Dr. Amal Ibrahim, assistant professors. A female patient, 56 years old, underwent left malignant mass lumpectomy, received chemo and radiotherapy 2 years ago. Now she is complaining of new left breast lump, 2 months duration. We will start with mammography. As we can see, the left CC, an area of irregular area of high density causing architecture distortion associated with thickened skin. And here we can see the microcalcifications. Then the patient underwent ultrasound. As we can see, a thickened skin and an area of high echogenicity causing massive shadowing and calcifications, hindering proper breast examination. Okay, then here comes the rule of MRI. We here think about 2 options. First one is a scar tissue or a recurrence tissue, okay? Then one of the most important indication of MRI to differentiate between them. So what is the recurrence or the scar? We will start with the conventional images T1, T2 and STIR. As we can see, an area of intermediate to low signal in T1 and T2. And then we will see the most important, one of the most important sequences in conventional MRI is the diffusion and ADC. Here we can, an area of true diffusion restriction. Then we will come to the post-contrast subtraction images. We take post-contrast subtraction images at 1 and 2, 3, 4, 5, 6 minutes. Okay. We can see a slightly increase in the contrast enhancement rather than stationary contrast enhancement. Then we need a confirmatory point to see how to know what is the, if it is a scar or a recurrence. Then we go to do the time intensity curve. The time intensity curve will reveal one of the 3 types of the curves. The first one, our type 1, we will see a progressively intensity increase in the contrast enhancement, which indicate likely a benign lesion, almost. Type 2, we will see an increased enhancement, then a plateau enhancement, which is indicate also a benign lesion. And here is the worst case scenario, is the type 3 curve. As we can see, a rapid washout. That strongly suggestive of a malignancy lesion. We don't forget to look about the lymph node. As we can see, a right-sided lymph node, enlarged, rounded, loss of the fatty hilum with true diffusion restriction. So we recommend that this patient have a recurrence lesion rather than a scar tissue with a lymphatic metastasis. And unfortunately, the patient did a pathology report and biopsy and will reveal invasive ductal carcinoma and metastatic lymph nodes. This patient also has a benign lesion. We will present it fastly to see the controversy between the benign or malignant. Here is in the mammography, we can see a mass lesion, oval in shape with circumscribed margin. In the MRI, T1, T2 stir, we can see a low signal lesion. And in the subtraction images, we can see no contrast enhancement at all. But we can find in the delayed post-contrast images some contrast enhancement, which is a characteristic feature of a fibroadenoma. Thank you.
دكتورة منى نشأت هتقدم حالة تانية.
Good afternoon, everyone. I will be presenting a case about a 53-year-old female. Okay. Our case is a 53-year-old female patient presented with bearable pain. The first modality done was transvaginal ultrasound. Unfortunately, the images are not present. The transvaginal ultrasound revealed a complex adnexal lesion, partially solid, partially cystic, for better assessment by MRI. MRI was done at our unit. This is the sagittal C2 image, revealing a midline, a partially solid, partially cystic lesion. And then the axial images. As we see here, the mass is originating midline, partially solid cystic lesion, originating from the left ovary. These mass have two components with leveling. The upper component show a high intensity signal on T1 and low intensity signal on T1 fat suppression, with intermediate intensity signal on T2, which goes with fat component. And the lower part of the lesion show low intensity signal on T1 and high intensity signal on T2, which goes with cystic component. Diffusion and the EDC images show no diffusion restriction with facilitated diffusion only. This is abstracted post-contrast images, show a very thin rim of peripheral enhancement. And then there is a characteristic whorl sign seen here in the coronal view, twisted pedicle of the left ovary, and of course in the axial view. This is a finding reported by Dr. Asma. Left ovary is seen enlarged with edematous stroma and peripheral hemorrhagic cyst with a twisted pedicle donating torsion, likely arising from the left ovary, as mentioned, and it shows fat fluid leveling suggestive of mature teratoma, as there is no solid component. This is a full report. The mass was surgically excised, and this is the pathology report. The left ovary showed twisted, infarcted, mature cystic teratoma with no malignancy detected. I will speak briefly about teratoma. It's a germ cell tumor, ranges from benign, which is mature cystic teratoma, to malignant, which is poorly differentiated or immature teratoma. The complications ranges from ovarian tonsure, which is the most common complication, rupture, malignant transformation into squamous cell carcinoma, or endodermal sinus tumor if there is endodermal component, superimposed infection, autoimmune hemolytic anemia, hyperthyroidism if there is thyroid component, carcinoid syndrome, paraneoplastic, and glyomatosis peritoniae. We'll talk briefly about the most common complication, which is torsion, intermittent or sustained, acute or chronic. This patient goes with chronic torsion as the patient have bearable pain, and there was no history of acute severe pain, as we called the resident afterwards and reported that the patient have acute torsion. In case of torsion, we see an enlarged ovary, enlarged edematous ovary, unilateral, usually with the right side pre-reduction. Secondary signs may be free peritoneal fluid, underlying ovarian lesion may be present, reduced or absent vascularity, and twisted dilated tubular structure which correspond to the vascular pedicle. In this case, we see the right ovary is enlarged with no detected vascularity on color Doppler application in comparison to the left ovary. This case is the same. Enlarged right ovary with no detected vascularity at all on Bauer Doppler application in comparison to the left ovary. This is a coronal CT view for another patient with a positive oral sign, which is characteristic to the torsion. We will talk briefly about the immature ovarian dermoid cyst, which is the malignant type of the dermoid cyst. It's characterized predominantly by a solid component with few foci of calcification and fat. Immature teratoma tend to be larger at time of presentation than the mature one. Extension through the tumor capsule may be present. Immature teratoma may metastasize to peritoneum, liver, or lung, and metastasis to the brain has also been reported. In this case, we see here A and B are the CT images of a patient with immature teratoma showing few foci of calcification. C is a MRI T1 sequence with few foci of hemorrhage inside immature teratoma, and D is immature teratoma with a solid component detected inside. This is another case with complicated immature teratoma by rupture with massive ascites and peritoneal deposits. The take-home message here is a clinical presentation of mature ovarian teratoma, which is usually asymptomatic in 90% of the patient unless complicated. Common complication, torsion. The most serious complication, malignant transformation. Immature teratoma will difference from the mature. Thank you. Special thanks to Sarah Al-Badawi as it's her case.
Thank you, Dr. Minna. Thank you, Dr. Sarah.